So I'm Caris, I'm one of the 5th years at the uni. I'm at home at the minute because I'm isolating, and I'm incredibly bored, which has led me to creating some oncology slides. So basically I'm just going to start by running through, so it's oncology for finals, but I'm going to start with like running through the basics, which is essentially stuff that you did in like 2nd and 3rd year. So like oncogenes, tumor suppressor genes and stuff like that. And then if you can just tell me if it's too basic, that's fine. I'd rather just go off people's feedback and kind of progress through the teaching based on what you're all saying. There's some cases at the end, and I've put in some like clinical stuff throughout it. But bear with me at the start. I'm going to try and like rush through some of the more basic stuff like hallmarks and things like that. But I just wanted to go into some of the concepts because I think with oncology, it's one of them things where you just do it bit by bit as you go through the specialties, but no one actually really teaches you oncology in like, well, you have an oncology week in 4th year, but whatever. But, you know, you don't really like go back to your 2nd year notes when you're in 4th year. So this is just sort of makes it a bit easier because you've got it all here, things like the hallmarks of cancer and things like that. So I'm going to start now, I think. But yeah, bear with me if it's really basic at the start. And tell me if it's too basic. Like if we're a good 10 minutes in, it's already still too basic, then just tell me. Okay. So, oh, why is it not? Okay. Right. So, yeah. So I'm going to start by going through just like basic pathophysiology, and like just basic principles, then going into like the 4 most common cancers, but I'm really not going that deep into the clinical stuff until I get to the cases at the end. 2-week criteria, I'm not going to run through each one specifically because there's a lot, but I've linked where you need to go to get all that information and what I think you need to learn. And then just put some of the like random bits on along the way, like staging and stuff like that. But it's all quite principle based, but if you just like tell me if it's too simple, I'll move on. That's fine. So what is cancer? Okay. Essentially this is like natural selection gone wrong. You start with a cell that has a set amount of, you've got like your set amount of DNA in your chromosomes, and mutations occur, and any mutations that convey an like selective advantage or an advantage to growth essentially allow for cancer, and if it evades the immune system then and develops certain phenotypic traits such as like the hallmarks of cancer, then essentially you'll get something which will evolve and continue to mutate, continue to replicate, and you'll get something called clonal expansion, where all of your cells will come from one lineage and all replicate non-stop, uncontrollably, and that's when you've got cancer. That was a really long-winded explanation. So this is the clonal genetic model of cancer. So as I said, you start with your cell, and if you've got a mutation which enables the cell to replicate an unlimited amount of times, or replicate at a faster rate, which means it's more likely to progress through the cell cycle with mutations without getting rid of those mutations as it progresses through, then you end up with clonal expansion of one cell lineage. So just understanding this concept, clonal expansion, clonal genetic model of cancer is important. Is anyone, I don't know how to get the chat up so that I can see it while I talk, because then you can tell me if it's too basic. Right, I'll just look at it every so often. So the selective growth advantages, the mutations which are advantageous to growth all come from either a gain of function of oncogenes or a loss of function of tumor suppressor genes. So with oncogenes, you've got an example being KRAS. You've got a GTPase which resides just under the cell surface, conveys growth signaling into the cell and enables that like propagation of growth signals to continue replication, to continue cell growth. When it's constitutively active because it's mutated, or when it's and in excessive numbers, and you've got like lots of KRAS, you've got more signals coming through, making their way into the cell, and the cell is and can replicate without growth signaling. So oncogenes are usually more responsible for that side of things, whereas tumor suppressor genes are more responsible for sort of evading like inhibitory signals. So examples being RB, retinoblastoma. So obviously you see that in retinoblastoma, but this is actually from cervical cancer. So if you know HPV, the virus, has inserts these genes E7 and E6 into the genome when it attacks cells, invades cells. And when it does that, these genes then inhibit tumor suppressor genes such as retinoblastoma and P53. And if you inhibit these tumor suppressor genes, then this is involved in cell cycle functioning. So it's essentially a cell cycle checkpoint. So if you inhibit it, then the cell will just progress through the cycle, and you will lose that checkpoint to get rid of any that's there to get rid of any mutations before the cell replicates. So you'll end up with a cell replicating with mutations, and then you'll end up with cancer. So for example, that's how cervical cancer comes about when it's HPV related, which most are. And then with oncogenes, you've got gain of function. So as I said, KRAS, you've got RAF. RAF is, you might know BRAF, which is often mutated in colorectal cancer and in 50% of melanomas. So if this is constitutively active, then it doesn't matter how much growth signaling you've got here. It doesn't matter how much KRAS GTPase function you've got. If RAF is constitutively active, then you've got that propagation and cell growth. Can we move on to... So just while we're on the topic of tumor suppressor genes, you need 2 hits to get rid of your 2 copies of tumor suppressor gene. So you've got, obviously we all know we have 2 copies of each chromosome. So you've got 2 copies of each tumor suppressor gene. If you already have a DUD tumor suppressor gene because of a mutation that you've inherited, for example, in retinoblastoma, if you've got a retinoblastoma mutation, then you're going to get, it only takes 1 somatic mutation to then get that start of, the start of that cascade, which leads to retinoblastoma developing. This is so much more unlikely if you weren't born with a retinoblastoma mutation already. And this is Newton's 2-hit hypothesis. So just a basic understanding of that and how it leads to things like this, which is essentially sporadic versus hereditary cancers. So where you haven't already got that mutation, as I said, you're so much less, sorry, as I said, if it's sporadic, you're so much less likely to then get 2 mutations, that you'd likely be a patient who's older. So you get patients who present a little older with retinoblastoma when it's sporadic versus when it's hereditary, when they're usually like 1 year old. They might even be told, like, they might even be neonates presenting with like cataracts, and you might have them in both eyes because they were so much more likely to get retinoblastoma because they had that mutation. So yeah, okay, so I'm really not going to dive deep into the hallmarks of cancer, but if you understand all the principles that I've just talked about, then you understand the hallmarks of cancer. It's essentially just the phenotypes behind a cancer cell which enable it to be a cancer cell. And all of these come from advantageous growth mutations. They're all just a consequence of various mutations in oncogenes or tumor suppressor genes. So yeah, as I said, so they lead to a predictable phenotype or phenotypic hallmarks, and that's what makes the cancer cell a cancer cell. So I'm not going to, do you want me to go through all of them very vaguely, or do you want me to just skip? I've got 10 slides here. like one on each hallmark. If you just tell me on the chat, I think I can see. Skip, cool, okay. Yeah. General consensus is skip. Yeah, cool. Well, I'm just gonna go with you two. So I've just put like a little bit about on each one about how they apply as well. So for example, when you're invading growth suppressors, you've got APC, loss of contact inhibition, and this relates to FAP. So if you understand that, then you understand how FAP happens, FAP occurs. Yeah, so you can look through this in your own time. Actually, I just want to quickly go back through. So just to go quickly through one, so genome instability and mutation. So I just want to mention this just because when you've got genomic instability, cancers often respond. So all cancers have genomic instability, but cancers that have excessive levels of genomic instability, for example, if they've got mutations in like mismatch repair genes, then they often have more mutations happening all the time, which means the cells are all more different, which means they respond less effectively to treatments. And this is relevant in colorectal cancer, particularly in HNPCC, because as you know, HNPCC, you've got your MLH1, MSH2, various mismatch repair, like DNA machinery, which are what's mutated, which causes the cancer in HNPCC. So if you don't have that machinery, you're not going to repair mutations as well. You can have even more genomic instability. And that means that these tumors are generally more aggressive and don't respond as well to treatment. But yeah, so if you needed just to recap the mismatch repair machinery that is mutated in HNPCC or Lynch syndrome, then it's these. So yeah, but you can read all this in your own time. Okay, so I'm just going to go very briefly through the Vogelgram because I think I read this in so I remember looking at this in second or third or fourth year or whatever and not knowing what I actually need to know from it. Essentially, I think if you just understand, everybody already by now knows the adenoma to carcinoma like progression, like the cascade. As long as you've got a basic understanding of how that happens, which everybody already does, then you're fine. I don't think you need to revise it for finals, other than I would learn the main genes which are mentioned in the Vogelgram. So for those who don't know, the Vogelgram is just the progression. It's just like a diagram of the progression from an adenoma to a carcinoma, and it's an example essentially of like a model of somatic evolution in cancer. So it's an example of the accumulation of different mutations that then eventually lead to the benign early adenoma becoming carcinoma. I would just say if you learn these 4 genes and just the order, I mean, that would take you like 2 minutes. APC is, as we've already talked about, relevant to FAP. It's like, I think it regulates beta-catenin, so it's involved in like cell adhesion. So if you have like insufficient levels or insufficiently functioning APC, either through mutation or because you had that in your germline DNA because of FAP, I hope this isn't too many abbreviations, then you essentially, if you have FAP, for example, you already have the start of the Vogelgram. So you've already got like this key mutation is already there. So that means that your beta-catenin isn't being regulated. So your cell adhesion isn't being regulated. Your cells are able to grow like around each other and not have that regular sheet-like epithelial structure which cells in the GI tract should all have. And then once they can do that, then they can start to evade all the other, all these other like regulatory things as they progress, because they'll get more mutations because they're growing abnormally and able to do that because of APC. So I'd say learn APC, KRAS, SMAD4, P53, you don't need to understand the complexities. Just that, you know, P53 is a tumor suppressor gene, KRAS is an oncogene, we should all know that by now. APC, we know that because of FAP. Just learn them, learn the order, yeah, I'd say as long as you understand that the further you progress down the Vogelgram, the more genomic instability you have, because the more mutations you've accumulated. And earlier on in the Vogelgram, the more people have that mutation, because essentially more people have it because it's the first one that you have in order to then progress. So APC is present in, I think, like 95% of colorectal cancers. That's why it's right at the start of the Vogelgram. I hope that makes sense. Does that make sense? I'm going to carry on anyway for now. So that's just some more information about the Vogelgram. The earlier in the sequence, the more patients have with the mutation. Yeah, it's just concepts. When you understand it all, it's much more easy to learn oncology, I think. So just to quickly go through grading. So grading is different to staging in that your staging is looking at the spread of the cancer. The grading is look at how aggressive the cancer is. And essentially you grade a tumor as it's diagnosed, because you need to assess the grade of a tissue in order to diagnose that there is malignancy there. So these are like 4 features of any malignancy which you should just know and have a basic understanding of, in terms of like, this is essentially these 4 features. So abnormal hypochromatic nuclei, loss of normal polarity, pleomorphism, which is like the variability in cells, and atypical mitoses. If these are present, then you've got a malignancy or at least some dysplasia. And the extent to which these are present is how tumors are graded. But yeah, if you just understand those 4 concepts, then you'll understand how cancers are sort of assessed and diagnosed, because that's how they're diagnosed, just by the assessing the extent to which they're present within a tissue. So they're graded generally low, intermediate, high. If they're anaplastic, so they might have like lots and lots of abnormal mitoses and no obvious like characteristics, any particular cell type, like tissue type. They look just like random cells, or maybe they look out of place. Like in some lung cancers, you can get cells that look like, I think it's adrenal cells, but they are lung cancer cells. They've just mutated that much. They've gone almost beyond anaplastic, and those tumors would be particularly high grade. And some malignancies have their own specific grading system. So just remember Gleason grading in prostate cancer. They take, I think we've got it on the next slide. Yeah, so they take the 2 most common patterns within the tumor. So you've got your tumor, and within it, the 2 most common sort of like areas of dysplasia, they'll look at them both, they'll score them both, they'll add that together, and that's how you'll assess whether there is any malignancy, and then how malignant or how high grade it is. So that's grading. Different to staging. Also obviously really relevant within assessing your cervical cancers, because of CIN 1, 2, and 3. You've got if you've got that intraepithelial neoplasia in 1/3, you've got CIN 1 progresses to 2. If you've got 2/3, if you've got full thickness, that's CIN 3, or it's carcinoma in situ. So essentially any cancer is just the degree of dysplasia, and then it's defined as cancer once it's evaded a basement membrane. And that's essentially how it works in all of the malignancies. And that's really easy to understand if you just understand grading, and if you understand like like cervical cancer and evasion of the basement membrane. So it's not anything other than carcinoma in situ. It's not cancer until it's evaded the basement membrane. So yeah, staging, I'm not going to bore you with TNM staging, but essentially for finals, I like, obviously you don't need to learn like each TNM stage for each cancer, but like, I think I like just had a general idea of like different ones for different cancers. For example, like kidney, I think it's, if it's over 4 centimeters, then it's T2 or something like that. Like I don't know, I think that's probably excessive actually. I think probably just understand what TX is, what T0 is, and understand the concepts obviously of TNM staging, but I'm not going to go into that because you probably already do all get it. But that's just describing the spread of the tumour across the body, rather than how aggressive it actually is, which is grading. So yeah, I think this one is from, oh, this is renal, is it? Anyway, I've just taken one here as an example. Right, so these are just some exceptions which really annoy you when you're doing your revision finals and you're like writing down, like say you're doing GI and you're like going through and you come to cancer and then like you just go through like the investigations you need to do, and like differentials, blah blah blah, and then when you come to staging and you just think, oh, it'll be TNM, and then they've got these like rogue ones. So just to bear in mind, have some awareness of Breslow thickness for melanoma. I'll discuss that a little bit later when I go through the cases, but that's more the depth of the cancer rather than the size of it when you're talking about like T in the TNM. So that's melanoma. And Arbor phases are in lymphoma, and that's these, I think. So you've got your presence or absence of B symptoms to take into account, and you've got whether the tumour has spread like above or below the diaphragm, and whether it's spread to other organs as well as just random lymph nodes outside of the other side of the diaphragm. So that's Ann Arbor staging. Duke's classification is really similar to TNM. So mainly they use TNM for colorectal cancer, but Duke's is just kind of like A, B, or C, and A would be like T1, B would be like T2, T3, C would be like N, like T3, N something, D would be like metastatic. Just having an awareness of that exists. Gynae, you've got like your FIGO staging. I don't think you need to like learn that. I think you just need to know that they use FIGO staging. So yeah. Right, so do you want to tell me what the 4 most common cancers are in the UK? On like the chat, breast, lung, prostate, bowel, yeah. So prostate, breast, lung, colorectal, and you can find these stats of cancer research. They have all these pretty diagrams. So there isn't much to say about this, except in, I think it was my finals, or it might have been like my fake finals, they like asked what the most common cancer, the most common 4 cancers were in the UK in like order, and I was like, oh, I don't know if bowel is first or lung is first, or I knew it was these 4 but I didn't know which one was first. So might be worth just noting that it's breast, prostate, then lung, then bowel, but like they don't recycle questions necessarily, but if they did, that came up in mine. Right, so this is a bit of a useless slide. This is just a few points about the big 4. This is an easy stat to remember, which I think comes up a lot. Prostate cancer affects 1 Caucasian men and 1 in 3 Afro-Caribbean men. So ethnicity, we all know that's a big risk factor for prostate cancer. I think that's that, just like you get asked about things like that. Most common lung cancer is squamous. Adenocarcinoma is like increasing and like starting to overtake as smoking decreases in the population. So just here where it says lung is the second most common in male and females, I know there it looks like the third most common, but it's because breast isn't the second most common. No, prostate isn't the second most common in females, if that makes sense. Breast isn't the first most common in males, if that makes sense. So like colorectal cancer is like the fourth most common cancer in the UK, but the third in men and women. It just doesn't really sound like it makes sense, but it's just because these obviously apply to one gender, one only. So, okay, so in terms of your, like when you revise it, you obviously are going through like your symptoms. I'm not going to go through the symptoms for every cancer, but you'd go through like your symptoms, like your classic symptoms, and then when to refer is like a really, really important thing to know for finals, because obviously finals is so case based. The thing which you are probably asked most is like what to do when a patient presents with a certain symptom, and your red flags are really important. They ask about so many different ones in your finals and in third year a bit as well. This is like from memory, but like I'm fairly sure like it makes up a fair bit of the exam curriculum. So learn your red flags. I can't go through every single red flag, but I just thought they're really important. So I've attached the document here, which I used to revise them. I just printed this off before finals and I just learned them all for like every malignancy, because you need to know essentially this whole document. You need to essentially know all of the 2-week wait referrals and the referral guidelines for suspected cancer pathway. You need to know all of that for finals. So click on this, and if you haven't got it already, print it off and highlight it, and yeah, just know that for finals. It's also relevant in third year for cancers which you've gone over into CCT. So I remember in CCT they taught us the suspected cancer pathways for colorectal cancer, and then a lot of that came up in third year exams, because they do that a lot. Like anything from CCT, they love to bring up, because it's the only teaching which is not sort of trust specific or doesn't deviate between trusts, so everyone gets a very standardized set of teaching through CCT. So they love to include CCT content in your exams. So if you did do any 2-week wait referral guidelines and you're in third year, don't think that they won't come up until fourth year, because if you've done them in third year, they might still come up. So know the relevant ones that you've already been taught in third year, know them all in fourth year. And they're all on here. Within this document, they list like whether the referral is like needs to be an urgent referral or non-urgent. So essentially your 2-week wait pathway is your urgent referral. And this is like the most common referral that they use. But for some cancers, like acute leukemia, they use very urgent referral or immediate referral. So I've just put here what they mean when they say that, but it's all in the document. So you can kind of learn them in terms of like the malignancy, that they're in the booklet sectioned into malignancies, but then if you scroll down a bit further, you can learn it by symptoms. So you can kind of know in your head like, oh, change of bowel habit, and then think, oh, is the patient over 60 and like a male or female, or are they over 50 and are female, and whether it's relevant to ovarian cancer or colorectal cancer. But I learned them by learning just learning it by cancer type, and it is really awkward with regards to like the age, like that the guidelines are different for like different age groups, and the age groups are different in different cancers. But just learn them, they come up, and you need to know the ages, because it's just one of those things that you can just guarantee you need to know. And obviously it is useful to know as well. Right, so sorry I couldn't go through them, but there's just like, the document is really big, and I just recommend just rote learning it for your finals. So do it when it's really relevant. So you'd go through your symptoms, obviously, when you're looking at a cancer, you go through your symptoms and your referrals, And then you'd go through what investigations you would do, which obviously vary between different malignancies. But one thing that does really vary between different malignancies is like your very specific blood tests, so like your serum biomarkers. So these are like the biomarkers which I thought are most relevant for finals. They ask about CA125 quite a lot, CEA, and PSA. Oh, I haven't got PSA on there, but PSA, obviously they like drill that in you, like they teach you that to death, so everyone knows PSA for prostate cancer. But these are just other ones that I thought might be relevant to learn for finals. So if they're asking you, for example, what investigations to do in a patient with suspected colorectal cancer, for example, you'd obviously put like your FBC, because you want to see if they've got any like anemia or thrombocytosis, and CEA, pop that on there as well. And then if it's pancreatic, CA19-9, CA15-3 for breast cancer. These just kind of come up in MCQs, and you see them on like Past Medicine, things like that. So yeah, some of them aren't used at all in diagnosis. Some of them are, like CA125 is, but mainly they're used in like staging. For example, LDH makes up part of the melanoma staging. And I think HCG and AFP you'd use for diagnosis when you're like investigating with lumps, like dermoid tumours and things like that, because this is obviously like germ cell tumours in younger people. But like CEA, CA15-3, CA19-9, they're more used like to like track someone's progress, their response to treatment, and then say their CA19-9 goes down because they've had those treatment, and then all of a sudden shoots up again, then you're going to like reinvestigate that person to see whether their cancer's come back, and that's what those ones are used for. So this is just to show that LDH is used in staging of melanoma. So it's actually like when you have metastatic disease, they like group you according to your LDH, because your LDH goes up if you have advanced melanoma. Right, metastases. So I'm not going to bore you to death with the definition of metastases, but I just wanted to put some like useful things on here that you might not think to look up. So essentially, where a cancer metastasizes to is not random. It's different for different cancers, and it's very characteristic pattern. It's called metastatic tropism. Basically means that they have a predilection for different tissues, just based on where that tissue will like survive, where that cancer will like survive best. It's but ones which are good to take note of are like your epithelial tumours. So I can't even think of most tumours. I can't think of so like your breast, prostate, lung, renal cell carcinoma, I think thyroid. These are the ones which like most commonly go to bone and cause bone mets. Bone and sarcomas always go to the lungs. So if you have a PEDS case and it turns out that it's Ewing sarcoma, for example, and they're like, where might this metastasize to? Put the lungs. If it's a sarcoma, it will go to the lungs. Same with like rhabdomyosarcoma. Colon cancer goes to the liver first and then often to the lungs as well. If it's a rectal cancer, then it more likely goes to the lungs first, because the blood supply, I think, goes directly into the inferior vena cava from the rectum. But if it's a colorectal tumor and it's more like right-sided, then it's more likely to go to the liver first, because the blood drains to the liver first from there, whereas in rectal tumors it doesn't. But yeah, the most common cancer mets are hepatic and pulmonary. And bone mets, you'd find them, that you might find them first. They're often, for things like prostate cancer, they're often like they're often like the presenting feature, because you get people with pathological fractures or often with back pain. and you would investigate bone mets with a technetium-99 isotope bone scan. So remember that, just because it's relevant to literally all cancers if you're investigating for bone mets. That's what a bone scan is when people say about do a bone scan. So there's different types of bone mets: osteolytic, osteoblastic. Like I said, the most common things to metastasize to the bone are like your thyroid, breast, prostate, renal, lung cancers. They're all epithelial cancers, so they're carcinoma rather than like adenocarcinoma. Right. Well, they're carcinomas anyway. They're not like sarcomas. And essentially, the ones you need to remember things like prostate are osteoblastic, so they cause like characteristic like really poor, like really bad bone pain, and I think you can get like spinal cord compression, like really badly in like metastatic prostate cancer. And then your mixed ones are breast, testicular, ovarian. Your osteolytic ones are thyroid, renal cell, and lung. So basically, if it's osteolytic, then it breaks down the bone. If it's osteoblastic, it builds up the bone. And if it's mixed, it does a bit of both. And in terms of managing these, I just put a little side note at the bottom. Remember your WHO analgesic manner. They ask about like managing like symptoms and stuff, obviously in like palliative care, which is not really relevant to what I'm doing now, but it's just something to always remember when someone's got bone mets, that mention your WHO analgesic ladder. If you mention that in an OSCE, then they'll love you. It's like NSAID first, etc., etc. Yeah. So I've just put principles of treatment. I think I'm just gonna like rush through this. 1 second, sorry. Yeah, so if you're in an OSCE, this is more relevant to OSCE, which I don't know if your OSCEs have been cancelled this year. But anyway, obviously you also get like short answer questions in exams. So if they're ever asking you about management in malignancy, then obviously it might be chemo, it might be radiotherapy. It's different for different cancers. It might be both, it might be chemo, radiotherapy, might be surgical with a bit of like neoadjuvant chemo, adjuvant chemo. But it's always MDT. So always mention it, because especially in an OSCE, they love it. Yeah, so treatment varies for different cancers. I put a couple of just random principles of chemo up there. So obviously when you've got uncontrolled cell cycle progression, uncontrolled cell growth, you need to stop that, and that's essentially what chemo does. They all work differently, and therefore they all have different side effects. You don't need to know different side effects for every single different chemo agent. I never remember being asked about any particular chemo agents in finals, other than like, in fact, no, I don't think any particular chemo agents they'll ask about in particular. But it is good to know about side effects, like long-term side effects that are found, or like follow-up of patients who have successfully been cured of their cancers. So methotrexate causes pulmonary fibrosis. It's a good one to know. It's always on like past medicine, and it comes up in like little MCQs. That also happens with bleomycin. Peripheral neuropathy, know that for vincristine. That's a big one in kids who've had like leukemia. So like your ALL, kids who get ALL quite young, they then have like neuropathy which might last just until the end of their treatment, or it might last for the rest of their life, and they might limp and things like that. So good one to know. Mucositis, most chemo agents cause mucositis. 5-FU, which is used in colorectal cancer, is a really big one for causing mucositis. Doxorubicin and cardiomyopathy, that's a good one to know, good thing to know. Yeah, I think these are just generally like things which would be like a 1 marker. It's not really, at the end of the day, if you didn't know this, like you'd lose like 1 mark, but they're all just things that might help, just side effects to learn if you're interested. yeah, and myelosuppression happens with virtually all chemo agents, and it essentially means that you'll get like pancytopenia, and then you've got like immunosuppressed patients. That's why patients right now, cancer patients currently, are all having to like self-isolate because they're all high risk because they're all pancytopenic, or at least their blood, their cell counts kind of wobble around this quite low axis. So they're all relatively immunosuppressed all of the time. So they're at risk of like neutropenic sepsis, and that's right now. I think a lot of chemo is like not happening because of the current situation. Radiotherapy, so it just kills DNA, and yeah, it can be used with chemotherapy. This is then called neoadjuvant, concurrent, or adjuvant chemoradiotherapy if it's used with chemo. Neoadjuvant is when you use the chemo before, concurrent is when you use them both at the same time, adjuvant is when you use the chemo afterwards. It's different for different cancers. The ones where you'd use chemoradiotherapy for is like rectal, esophageal, lung, cervical. There aren't many because it's really, really, really intense treatment, like really bad side effects, like locally, because it's local treatment and systemic treatment at the same time. It's just really nasty. Novel agents, so there really aren't many that you need to know about, but these are just like your targeted therapies. Ones that you do need to know about are, I wrote down here, I think, so imatinib. So imatinib, or you might have heard of it as Gleevec, is used in CML. It's kind of Revolut treatment, and really improved the prognosis of patients with CML, which was quite a dire prognosis. And what imatinib does, it targets the Philadelphia chromosome, or the proteins which that forms. So the Philadelphia chromosome causes like a novel transcript and a new protein to be made within the cell, which is then constitutively active and enables like constant signaling, constant growth signaling. And imatinib just inhibits that tyrosine kinase, so that you haven't got the propagation of that signal anymore, and the cells die out. Then eventually resistance built up, and they put you on a second line agent and then a third line agent, because often, I think these patients like often relapse after a couple of years, but it's so much better than patients with CML who used to just get really ill quite quickly, get a blast crisis, and just like progress really rapidly. Whereas now, CML isn't such a bad diagnosis to have, all because of imatinib. So they like you to remember that one. Melanoma, the treatment has become like really immunotherapy heavy, so that might just be something to bear in mind, but I don't know how much they really would go into that for like melanoma. I think it's mainly just imatinib you need to know, but yeah, I put a couple of others on there, but yeah. And if it says IMIB in the name, then it inhibits tyrosine kinases. If it says MAB, then it's an antibody, inhibits like cell surface things, I think. That's a blank slide. Oh, no cases. Okay, right. So I'm going to go for a couple of cases really quickly. I've got 15 minutes. So I'll try and go for at least the first two, but I've only got 3 anyway, because I wanted it more to be like concept based. So this is a PEDS case, and it's actually based on a patient who I saw on my placements. So you've got a 3-year-old boy who presents to walk-in with his mum, and his mum reports that his left eye started going very slightly red before bed last night. She's unsure if this was because he kept touching it. Significantly worse in the morning. It's all red and swollen, erythematous all the way around the eye. And it's sort of like pushing down on his eye, like this on his eye socket, so that his eye's sort of bulging out. It's got like that exophthalmos, and yeah, it's just really sore and irritated. He's also had a cold for 2 weeks and hasn't been his usual self. He's got less of an appetite. He's got a few petechiae on his ear. It says right ear there, and it says left eye, but yeah, we'll pretend it's right eye. You check EMIS, and it turns out they presented to the GP last week because the patient had abdominal distension. So what sort of alarm bells are ringing? What are you thinking? What else do you want to know? I'll just watch the chat. I don't know if you're like just not chatting or if or if no one's still 41 people. So is there anything else you want to know, or is there anything which you think like what sort of alarm bells are ringing right now? You've got a 3-year-old boy who is okay, family history, weight loss, good. Is his vision affected? This would be good to like look at from like an ophthalmology perspective, but like is actually not relevant because it's kind of just like a red herring to like take you off in the wrong direction. So the big thing here is like the red flags. So 2 weeks he's been ill. He is a toddler. They are ill all the time, but he's got abdominal distension. The GP prescribed Senna. And so obviously we can assume that the patient was reassured, but then they've come in and he's quite unwell. He's got petechiae. It's mainly the petechiae and the ongoing infection with another superimposed periorbital cellulitis that you're worrying about. Like, why is this kid so, why is he not his usual self? They always use things like that. So in terms of other things you might want to know, so he's born healthy, no relevant past medical history, is up to date with DIMS, normally eats well, but he's off his food, so he's lost his appetite. Everything else is normal. Any investigations you want to do? FPC, fab, yeah. Yeah, so essentially what you could say at this point is like, oh, he's got periorbital cellulitis, so you'll give him antibiotics, but this is just a red herring, and they obviously do that in exams all the time. So the main issues we're worrying about is his like persistent cold, anorexia, petechiae, tiredness. I don't think it even said tiredness, but he was tired anyway. And he might have some abdominal ascites because he's really distended. So you're going to examine him. You're going to want to feel for any hepatosplenomegaly. You're going to want to look for any other petechiae. I think someone said that. Examine the lymph nodes, perfect, because thinking, could this be like lymphoma as well? You're going to look at his throat and his chest, good, yeah. You're going to just generally do a bit of an infection screen on this kid because you're worried someone who's is he quite unwell? Do we want to just double check that he doesn't have sepsis? But the most important thing here is he's got like a few really classic symptoms of leukemia or a hematological malignancy. So he needs an FBC with a blood smear, like ASAP. You'd also want to get an LDH because that's elevated in leukemias and lymphomas. Blood cultures because he's got an infection. LFTs and UZVs because you always do them. Chest X-ray, maybe. Transabdominal ultrasound scan. This would all just depend on these bloods. So they're not relevant right now. So if you go on to what his bloods were. So what do you think about his bloods? The main things being, well, I've put them in bold, but the main things being blast cells, that's not very good. He shouldn't have any blast cells, and he's got lots of blast cells. Pancytopenia. Yeah, so you've got low platelets, like very low platelets, sorry, low neutrophil count as well, low red blood cells. So he's anemic, his HB's low. Yeah, he's got pancytopenia. We're quite worried about this this patient, so he'd need to be admitted like urgently. If you look at his blood smear, there's a population of medium-sized blast in keeping with acute leukemia. So this patient would be phoned up, they'd phone his mum, they'd say, you need to come to Alder Hey right now, and then they would come and they would have all those tests that I said there. So we would need a chest X-ray to look for any like lymph nodes in his arm pits, and any like perihilar sort of lymphadenopathy, or any other like any consolidation, like just in case. Transabdominal ultrasound scan because obviously spleen, the liver, like likely to be enlarged, especially if he's got a distended abdomen, and that might be that might be like due to infiltration of the lymphoma, or leukemia, sorry, in those organs. And he will eventually need like diagnostic tests, so your aspirate, with your immunophenotyping and cytogenetics. So if I go forward, so the patient was taken to sent straight to A&E based on the bloods. NICE guidance basically says that anybody who has suspected acute leukemia needs immediate specialist assessment. So immediate, I think, was within 48 hours? No, that's very urgent. Yeah, no, I think immediate specialist assessment is within a few hours, and a very urgent, so within 48-hour FBC should be offered to children with pallor, persistent fatigue. So he obviously, I didn't actually state whether or not he had a fever, but I'm assuming he did because I put it in bold. Unexplained bruising, which he had. Unexplained persistent infection, which he had. So based on these, he needed an urgent FBC. He had one. He's diagnosed with acute lymphoblastic leukemia based on the back of the peripheral blood smear and morphology. And so this patient was one who I saw at Alder Hey, and he had like a very severe periorbital cellulitis when he presented, and I remember seeing him and thinking, oh, is that like infiltration, because is this patient got retinoblastoma? But there's nothing to do with that. Like, it's just like a coexistent thing, and it can be quite a red herring, and it's very easy to just focus on that and just go, well, what's wrong with his eye, and think about it like in that sense. But it's often just a red herring. When you've got red flags, look out for them. If there's any red flags, even if there's something else which seems really relevant, they've got red flags, then follow the NICE guidance. So I've just put a bit about the heme malignancies. So essentially, you do your FVC, you do your blood smear, and then based on what they tell you, always do a chest X-ray, always do an abdominal ultrasound scan. CT CAP is relevant in most malignancies, and I think they would sometimes do that in the case of leukemia, just to look again at the spleen and the liver. And in terms of diagnosing acute lymphoblastic leukemia, your bone marrow aspirate with Trifine, which is like a core of your bone marrow. So they'll like get like 1 to 2 centimeters of your bone marrow, rather than just aspirating the liquid. They'll take it out. They'll run that through cytogenetics and immunohistochemistry. Sorry, it says immunohistochemistry. I meant immunophenotyping. And they will look at like the type of cells that are there. Like if you've got like all blasts, like here you've got loads of blasts, more than 20% I think is diagnostic. They'll then look at like different characteristics on the cells, and based on that determine what type of leukemia it is, and look at different genetic patterns. So do they have any fusions, like any translocations? Are they Philadelphia positive? That's all done on cytogenetics. So if you get an SAQ or an OSCE question, and it's like, what would you do? Obviously you remember your immediate FBC and you remember your chest X-ray and things like that. But when you say bone marrow aspirate, that's not diagnostic as per se. You need your immunophenotyping and cytogenetics as well. So always just remember to say that at the bottom, because in an OSCE it looks good, and in an SAQ it might actually be a mark which you'd otherwise miss out on. So yeah, I've just put a couple of things about various heme malignancies. So this is what you would have seen on his smear had we viewed it. In terms of like characteristic things of each of the 4 main heme malignancies, AML is Ararod's, Philadelphia chromosome in CML. It's like present in like 95% of CML patients. This is just like basically T922 just means it's a translocation between chromosome 9 and chromosome 22. And that's the same as BCR-ABL. you've probably heard of. It's, as you can see there, that's BCR and ABL, and it makes like a transfusion protein. So it makes like a new protein which causes more like growth signaling within the cell. And that's the thing which I was talking about with imatinib earlier, which imatinib targets in CML. And in CLL, you've got your smudge cells. Basically, the cells are really friable. And when you put them on a smear, you put the glass slide over and they all just like burst, they all lyse. So in CLL, you'll see smudge cells. So learn like these 4 things, because these are like if they mention our rods, it's going to be AML. You rarely get it in anything else. And in an exam, they wouldn't expect you to know that they would. So this is just a useful thing to learn. And I just put this diagram here because I just think it's really interesting. The acute leukemia is essentially a block of differentiation. So you get cells that are like really immature, hence why they're blasts, because they're not able to differentiate, and they're just rapidly produced and they rapidly divide, and they're just immature cells because they've not been able to differentiate. And the level at which they've differentiated determines what type of leukemia it is. So whether it's like pro-B or pre-B. Whereas like in chronic leukemia, you often have more of a picture where it's like the cells don't die. So in like chronic, I think it's, or for, I'm trying to think, is it CLL? In like chronic leukemias, the cells, rather than like having loads of blasts, you have like lots of older cells which are like avoiding apoptosis, whereas in acute leukemias you've got loads of blasts being produced all the time, with the exception of things like blast crisis, where like chronic leukemias can become more acute, but that's going down tangent. So a derm case, just to finish it off. Sorry, I'm over a little bit. I've got 2 minutes left, but I'm gonna carry on to the end of this case and then I'll stop. And then if you want to go through the 3rd case, then you can. So derm, you've got a 50-year-old patient who presents to you, her GP, with a new mole. It's on her back. She's got lots of moles. Maybe she's got like seborrheic keratoses. She's noticed this one's particularly different to others because it's got a bit pink and discoloured and sort of a bit irregular. She's never used sunbeds, but she loves going to Dubai for Easter holidays. What else do you want to know? Oh, sorry, someone asked me a question before. If patients with ALL are Philadelphia chromosome positive, can you use imatinib in ALL, or is it just using CML? That's a good question. I don't think they use it that much in ALL, but they probably could. But then you've got like specific, so like imatinib isn't only used in CML, but it's only used whether you are Philadelphia positive, and based on your cytogenetics is whether or not they'd use it. So they pretty much always use it in CML. Would they use it in AML is essentially what this person's asking. In ALL, if that patient was Philadelphia chromosome positive. I'm not 100% sure of that one, but I think they can, but I don't think that's like a standard thing. With ALL, you've got like lots of chemo regimens and it's really chemo heavy, and targeted therapies aren't really such a thing, particularly in peds from what I've seen. But in adults, where you are actually more likely to be Philadelphia chromosome positive if you're an adult with ALL, they might use imatinib. I'm not sure. I think that's one to Google, or I can Google it and find it out for you if you want. But that's a good question. That's interesting. Yeah, so back to the derm. If you can tell me like what you want to know about this patient in order to decide whether or not her lesion might be malignant. Any bleeding? Good. Risk factors, yeah. So like whether she uses sun cream when she's in the sun, family history, also her skin type. So is she quite pale or does she bronze, like tan really easily? So that's called your Fitzpatrick classification. I'll attach that in. Actually, I've not got it as a slide, but I've got it in some derm teaching that I did. Previous investigation, yeah. So, or whether she's had any others. If she's had any other skin cancer in the past, then we know she's really likely to be at risk. Size of the lesion, yeah, because you want to know whether it's over that like 6 or 7 millimeter threshold. Okay. So this is the lesion. So if you went down like the A to E approach, it's obviously asymmetrical. The border is irregular. The color is irregular. Like you've got pigmentation there that's really dark, and there it's really red, like erythematous. The diameter, I don't know, but it does look, I mean, it depends how close up the image is, but if it were over like 7 millimeters, then you'd be worried. NICE guidance says that we should be using the 7-point checklist in order to assess this and then score it based on that. So in terms of what this would score, so she's already told us that it's changed over time. So we know that it's evolved. So that's 2 points on the 7-point checklist. It's abnormal colour and it's irregular. So we know she's got at least 6 points, and I've got it here. So on the weighted 7-point checklist, so obviously ABCD is really useful to like understand and assess a lesion yourself. But when you're when you're thinking like in GP practice, am I going to refer this patient on a suspected cancer pathway? NICE recommend you use the 7-point checklist. So she would have scored at least 6 on this, based depending on what the size of her lesion is, based on the fact that she's had a change in size. She's reported a change in the lesion. It's quite irregular and it's a regular colour. So NICE state that anyone scoring over 3 on the 7-point checklist needs a 2-week wait referral for suspected melanoma. So yeah, so refer down suspected cancer pathway within 2 weeks if there's a score of 3 or more. Refer if dermoscopy looks suspicious of melanoma. That's more things that like GPs specialising in derm might have a derm scope, but wouldn't be relevant to finals. And in a nodular lesion, you would refer down the cancer pathway just because they can like look really, they can look like it's really difficult to like just look at a nodular melanoma and know that it's melanoma rather than like just a spitzoid lesion or like another different dermatology lesion. So obviously for your diagnosis you need tissue biopsy, but you'd examine it, you'd refer, derm would do a biopsy, and then management, you've got mainly you need to excise the lesion unless it's already like metastatic. So you would want to investigate you with like a PET scan and I think it's MIBG scanning. I think they use like a specific like type of PET scanning in melanoma. And then if it's based on whether it's metastatic or not and based on the grading, you would treat maybe with like palliatively with like chemo or immunotherapy. Like I said, melanoma is really like immunotherapy heavy now. So they target like the immune cells around the cancer and it attacks the cancer cells itself. So these are like therapies that sort of activate CTLs, like CD8 cells, like checkpoint inhibition therapies. But that's like really like rogue and not necessarily that relevant. And then your targeted therapies targeting BRAF. So 50% of these are BRAF positive. So just like a bit of a summary of melanoma, just for like the last few minutes. So there's a number of different types, like you've got your acral lentiginous, and you've got like your most common type, which is like a superficial spreading. Nodular melanomas are like really aggressive, but don't necessarily look like melanoma. So you need to watch out for them. It's the 5th most common cancer in the UK, so it's like just after the big 4. And its incidence is increasing faster than like any other cancer. You'll stage it using Breslow thickness and then TNM on top of that. And survival is, the thing with melanoma is it's very much dependent on the staging. Like the survival can be like quite bleak, or it can be actually like really good if a good excision is done really early on. So I don't know how much you need to go into like the different types, but just like know that you can get mucosal melanoma like in your mouth, ocular on your eyes. They're not related to UV exposure, it's only the cutaneous that is. And BRAF mutant, so the BRAF mutation V600E, which just means, I think it's the valine amino acid, is like substituted at place 600 for like a different amino acid. So this mutation is present in like 50 to 60%, and it's targeted by a lot of the targeted therapies. So it's something to be aware of, because if they asked you in like an SAQ, like, oh, what would you be looking for on like cytogenetic, well, on like your NGS, like when you're assessing a tumor, and like what mutations are like most common, and BRAF is like your number one for melanomas. So there's obviously lots of derm malignancies to like know about, but this is the most like sort of severe and like malignant like one of the three main ones. So I'm just thinking what I need to. Yeah, TNM, basal thickness. So I won't, do you want me to go through, I've got one very brief GI case if you want me to go through it, but I'm happy to stop there. If you just want my slides, they're already up. I uploaded them earlier today. So let me know now, because otherwise I'll stop. Or I can carry on if anybody's still wanting to watch. GI case, okay, that's fine. Sorry, my throat keeps gurgling, it's so embarrassing. Right, so this one's quite easy. I was like running out of time when I was doing this one, so it's just a very like nice guidance sort of approach. 57-year-old female reports new onset difficulty swallowing. She first noticed the symptoms 6 weeks ago. She's got a history of GORD, and she often has some sort of like discomfort after eating and like heartburn, but it's generally managed well with omeprazole, and it's been getting worse over the last few weeks. And the difficulty swallowing, she noticed about 6 weeks ago, and has progressed from difficulties just with hard solids to soft foods, and then now even liquids. So that's like a big red flag there. So what are you all thinking? What else do you want to know? How do you want to proceed? What's the big red flag? Weight loss? Yes, you want to ask if she's lost any weight. Any fatigue? Yeah. Just other red flags for GI malignancies. I think your big ones for like upper GI are like, your main one is difficulty swallowing, so dysphagia, but also adinophagia, so like pain on swallowing is also relevant. Weight loss is very important. Anemia is very important, but that comes more down into when you started investigating. Endoscopy is dysphagia's red flag. Yes, great. You need to do an endoscopy on the 2-week wait because of dysphagia. Dysphagia's always with the NICE guidance. I think dysphagia is like the only one in the upper GI NICE guidance where they'd automatically get an OGD, like a scope, within 2 weeks, even like no matter what their age is, if they've got new onset dysphagia. Whereas for all the other ones like weight loss, abdominal pain, anemia, nausea and vomiting, new onset heartburn, things like that, generally it's like, well, are they over 55? But dysphagia, if it says that, then big red flag. So no, mild unintentional weight loss, but no family history of malignancies of note. So your differentials here, because the main thing we're focusing on is the dysphagia, is your upper GI malignancy. So you're worried about an esophageal tumour, or maybe gastric. But other differentials could be, I just wrote them down in case they help achalasia. So that's when your lower esophageal sphincter obviously is, I think it doesn't open. So they have patients with achalasia have difficulty swallowing, but that also needs to be treated as well. So an OGD is still really relevant there. You won't go wrong saying OGD for dysphagia, basically. Could just be bad GORD and various like muscular things, MND, systemic sclerosis, things like that. So the patient needs, the patients need an upper GI endoscopy like ASAP. And bloods would also be useful because they might have thrombocytosis, anemia. So NICE says, offer urgent direct access, upper GI endoscopy within 2 weeks, so urgent, if they have any dysphagia, or if they're over 55 with upper abdo pain, reflux, dyspepsia. These are all like new onset. Because obviously if you've got patients that already have those issues, like already have GORD, then you're not gonna just scope them immediately. And this is just the rest of the NICE guidance for that cancer referral pathway. So that's all on the link that I attached just like in the middle of the slides. So just like, that's just the rest of the guidance. So if they have any of these symptoms, new onset, raised with like thrombocytosis, age 55 is the age that you need to sort of remember for upper GI referrals. But yeah, I think that's, I didn't put much on that one. Sorry, that case was quite brief. But I just wanted to emphasize the importance of dysphagia and how it's different with the different ages. So don't read it and see that is she 54, this woman? Oh, she's 57, but if she was 54, you'd still refer her. So yeah, on a red flag. So I think that's, so that's the end. I've got a link here. I think I need to like copy and paste it onto the chat. Wait 1 second. Oh, thanks for saying thanks. How do I paste the thing? So if you could give me feedback, I've sent the link. If it doesn't work, let me know. I don't know if that's the right link, you know, so it's Facebook. Right, well, I've sent a link, and if it works, then it works. But I'll post it on the Facebook page anyway as well. And if you could just give me some feedback, be completely honest, tell me if it was like a bit much, not enough, not clinical enough. Link works, great, okay. Yeah, you can like be brutal, I don't mind, because I'd rather like, if I'm going to teach again, like at some point this year, like or before like September, then I'd rather like just take that on board. And there's my email me if you have any questions. Like I genuinely don't mind, like I said, I'm self-isolating, so I'm really very free all the time to answer questions because I have nothing to do with my life right now. So yeah, thanks for watching, and yeah, give me some honest feedback.